So what we heard here today is quite interesting, that there's no doubt different views in regard to how to diagnose HCC. No doubt that historically, as we heard, the usage of the radiologic assessments to diagnose HCC has been in the norm based from the screening directive that were there in time. There's one key component that was brought up about the issue of cirrhosis or not. I have to admit that till today we have no clue even how to diagnose cirrhosis on the BCLC criteria, let alone the LIRADS. Nonetheless, there is this kind of preponderance to try to do this, but we do acknowledge, and we heard it from the experts, that sometimes, other than the extremes in regard to LIRADS, same like as we said in breast cancer as well, the extremes are great. We can confirm this is HCC, we can confirm this is benign disease, but the in-between, this is really where we might be lost and we might need something further to be dissected information-wise. We heard, more importantly, that actually combination of diseases together can occur. Actually, I totally agree that close to about, and it depends which series you look at, close to about up to 10 to 20% of patients might have combined cholangiocarcinoma and HCC. We cannot ignore that fact because treating the cholangiocarcinoma component is going to be as important. And of course, the genetic makeup, despite that probably the direct applicability on day-to-day basis in regard to HCC is not there yet, but it's coming. And I totally agree that at the end of the day, having the genetic analysis of the disease will be necessary for either research purposes, for either opportunities for clinical trials, or of course sometimes for completion of the workup that we're doing for patients. This is still debatable, but no doubt as oncologists, we kind of in the majority, rather than not, we definitely are doing some biopsies, even though we saw about the LIRADS and the usage of it in certain applications, especially for the rather confirmed for HCC. Quite interesting discussion, and I don't think we have any final answer in that regard. But with this said, I would like to kind of carry on a little bit more towards staging. And if anything, we've been using BCLC, or we hear about BCLC, which kind of like categories that not only split patients into stage, but also give guidance regard to therapy per se. And the question that I have is, and I'll ask with Mark here, do you use BCLC in your practice?
I always put in the note when I see the patient. I like the CLIP score better, Cancer Liver Italian program. It doesn't have performance score in it. And that's the bad thing about BCLC is I can take any hepatology or any hepatocellular carcinoma patient and ask them if they're tired, and they'll all say yes, and they have a PS performance score of 1 and automatically are a C stage.
I really picked to ask you this by chance, but you know what? I'm so happy you did, because you definitely excited me. Because I totally agree with you. In a paper that we published in JCO that came out of our group, we actually discovered that BCLC does not necessarily pertain much to the patients with advanced disease, with metastatic disease. And if anything, the one that scored the highest is exactly what you guys use, the CLIP. The Cancer of the Liver Italian program. And if anything, probably mostly this came from the idea that the patients in Italy get HCC for pretty much almost the same reason that they get HCC in the US. And that's probably where the correlation has been.